Hello, I'm Mike Rickels from the University of Pennsylvania, and thank you for the opportunity to participate in the workshop today and present the rationale for C-peptide preservation based on outcomes from islet transplantation. These are my disclosures. My objective will be to review evidence for the significance of varying levels of restored C-peptide production for metabolic outcomes in type 1 diabetes, and to relate the restoration of C-peptide production by islet transplantation to recovery of glucose counterregulation that is critical for the defense against hypoglycemia, as well as stabilization of secondary complications and improved quality of life. By way of background, with very low or undetectable stimulated C-peptide, beta cell replacement therapy by means of whole pancreas or isolated islet transplantation can restore physiologic islet beta and alpha cell function. Individuals considered for islet transplantation are also experiencing severe hypoglycemic events complicated by the presence of hypoglycemia unawareness or marked glycemic lability. Consensus guidelines recommend targeting a stimulated C-peptide of at least 0.2 picomole per milliliter for defining success of beta cell replacement therapy. And the Collaborative Islet Transplant Registry considers any C-peptide greater than 0.1 picomole per milliliter as indicating evidence of surviving islet graft function. The assessment of clinically significant outcomes for islet transplantation has incorporated measures of C-peptide as they relate to the achievement of glycemic control targets and reductions in insulin use and requirements. As an example, the beta score developed by the group at University of Alberta related the restored production of low amounts of stimulated C-peptide with achievement of glycemic control targets for the treatment of diabetes with reduced or low levels of exogenous insulin requirements, whereas higher levels of stimulated C-peptide were related with achievement of normal glycemia and the elimination of insulin requirements. There's the relationship with stimulated C-peptide has also been shown with continuous glucose monitoring metrics of glucose variability, which is used as an assessment of glycemic lability, as well as time spent with hypoglycemia, which together represent metrics that are significantly associated with future risk of experiencing severe hypoglycemia. And you can see from the standard deviation of glucose values from continuous glucose monitor that individuals with no measurable C-peptide invariably have standard deviation above 2.2 millimole per liter or 40 milligrams per deciliter, while with the restoration of even low levels of stimulated C-peptide, some individuals are able to achieve near normal glucose standard deviation despite ongoing requirement for insulin therapy, while those in the black dots that are insulin independent are all capable of maintaining normal glucose variability measurements with higher levels of stimulated C-peptide. And with time spent with hypoglycemia, there's also a continuous relationship as stimulated levels of C-peptide increase from low levels. There is already at stimulated values above 0.2 picomole per milliliter during mixed meal tolerance test, significant reductions of time spent with hypoglycemia that become absent by a stimulated C-peptide level above 1 picomole per milliliter. As you'll hear from Carla Greenbaum in the next presentation, with residual beta cell function in type 1 diabetes, there's also a continuous association with increasing levels of residual C-peptide as measure of beta cell function, and time spent in target glucose range by continuous glucose monitoring. Notably, those with high levels of residual C-peptide above 0.4 picomole per milliliter have time spent in target range glycemia very comparable to individuals who had no measurable C-peptide that was restored following islet transplantation to comparable peak stimulated values during mixed meal tolerance test. So this points out that the relationship of restored C-peptide to glucose control is similar to that with residual C-peptide in type 1 diabetes. And from islet transplantation, we also learned that higher levels above 1 picomole per milliliter may be required to achieve 100% time in the normal glucose range and independence from exogenous insulin. That relationship also shown here from the group in Australia, where stimulated C-peptide above 1 picomole per milliliter was necessary but not always sufficient for an individual following islet transplantation to eliminate insulin requirements, and that you can see that there's a otherwise wide variation of reduced insulin requirements with varying degrees of restored endogenous insulin secretion. The Collaborative Islet Transplant Registry has been established by the NIH and with support from the Juvenile Diabetes Research Foundation to follow prospectively those islet transplant recipients who've received cell therapy in North America, Australia, and Europe, and evaluate as primary outcomes those individuals who attain insulin independence, near normal glycemic control as determined by a hemoglobin A1C less than or equal to 6.5%, a fasting glucose within the range of 3.33 to 7.77 millimole per liter, the absence of severe hypoglycemic events, and as a measure of surviving islet graft function, a C-peptide of at least 0.1 picomole per milliliter. We've been involved with an analysis of 677 islet transplant recipients who prior to transplantation represented about 60% women who were mean age of 46 with mean diabetes duration 29 years, mean body mass index of 24 kilograms per meter squared, and requiring on average between 0.5 and 0.6 units per kilogram per day of insulin therapy, had negligible to undetectable fasting C-peptide, and hemoglobin A1C on average 7.9%. And for this cohort, 95% had impaired hypoglycemic awareness, with 77% having experienced a severe hypoglycemic event in the year prior to transplantation. They received almost 13,000 islet equivalents per kilogram, with 3/4 receiving islets isolated from more than one donor and delivered during more than one islet infusion. This cohort was evaluated for the relationship of fasting and mixed meal tolerance test stimulated C-peptide for the achievement of the CITR primary outcomes. Here, the combined outcome of hemoglobin A1C less than or equal to 6.5% and absence of severe hypoglycemic events had robust sensitivity and specificity for both fasting C-peptide in blue and stimulated C-peptide in red. And similarly, for insulin independence, could be predicted robustly with use of either fasting or stimulated C-peptide measurement. From this receiver operator curve analysis, Udin's index was calculated that optimizes sensitivity and specificity to form a threshold associated with primary outcomes. And as was shown with the smaller series presented earlier, low levels of fasting or stimulated C-peptide were already associated with absence of severe hypoglycemic events, with greater amounts of fasting and stimulated C-peptide being required to achieve near normal glycemic control, all of which was associated with the absence of severe hypoglycemic events. And then the greatest amount of stimulated C-peptide was required to achieve insulin independence, again at that approaching that threshold of near 1 picomole per milliliter. The relationship of fasting C-peptide to CITR outcomes was also evaluated over 5 years of follow-up, again showing similar continuous associations with the restoration of low amounts of C-peptide already having the greatest impact of establishing proportions of individuals experiencing absence of severe hypoglycemic events, with higher levels of fasting C-peptide required for the achievement of near normal glycemic control, that accounted for as well an absence of severe hypoglycemic events, and finally the highest levels of C-peptide required for insulin independence. And this relationship over 5 years was also seen with using peak mixed meal tolerance test stimulated C-peptide, with, of course, higher levels of peak than fasting being associated increasingly with absence of severe hypoglycemic events, the achievement of near normal glycemic control, and finally, the achievement of insulin independence. So the CITR analysis demonstrates the clinical outcomes of islet transplantation, including absence of severe hypoglycemic events, near normal glycemic control, and insulin independence are all strongly associated with the amount of restored C-peptide production. The absence of severe hypoglycemic events is observed already with low levels of restored C-peptide, while higher levels lead to greater proportions with near normal glycemic control and insulin independence. This avoidance of severe hypoglycemic events can be explained by the effect of islet transplantation on recovery of glucose counterregulation. These are data from hyperinsulinemic hypoglycemic clamp conducted by the group in Gießen, where individuals with type 1 diabetes experiencing problematic hypoglycemia were studied in gray. The black triangles give individuals previously experiencing problematic hypoglycemia who had undergone islet cell transplantation or evaluated 6 months later, and then finally compared with non-diabetic control individuals in the open circles. Importantly, this cohort of islet transplant recipients were all insulin dependent at the time of this evaluation, and you can see had very modestly restored endogenous insulin secretion, as indicated by fasting C-peptide levels above 0.1 picomole per milliliter. Nevertheless, this restored endogenous insulin secretion was appropriately suppressed during the induction of hypoglycemia that was achieved during the 180 to 240 minute time point of the clamp. And that was associated with a restoration of counterregulatory glucagon secretion that's absent in individuals with type 1 diabetes during hypoglycemia. And while this was remained significantly less than that present in non-diabetic control subjects, was sufficient to markedly increase hepatic glucose production, as shown here with the significant increase in endogenous glucose production during hypoglycemia in the individuals treated with islet transplantation relative to the type 1 diabetes controls. With this increase in glucose production being ultimately what defines glucose counterregulation and the recovery of a physiologic defense against the development of low blood glucose. There's also evidence for the effect of islet transplantation on secondary complications. This study of 45 individuals treated by the Vancouver program, where they followed individuals on the islet transplant waiting list, and then ultimately, once they received an islet transplant, following their cell therapy. And both groups accumulated several years of follow-up, which allowed an assessment of changes in glomerular filtration rate as a measure of nephropathy that progressed by a greater decline in glomerular filtration rate in the group receiving intensive medical management while on the wait list, with a much slower decline present in the cohort subsequent to receiving an islet cell transplant. Similarly, for retinopathy, many of these individuals had established diabetic retinopathy at the time of enrollment into their medical therapy, and ultimately those who crossed over to receive islet cell transplantation, such that not all 90 eyes were available for assessment for progression due to such advanced disease affecting 8 of the eyes, but you could see that under medical therapy, during which time 82 eyes were monitored, retinopathy progressed in 10 eyes, while as subsequent to islet cell transplantation, there were 51 eyes that could be monitored, and retinopathy progressed in none of them. An effect of islet transplantation on neuropathy has been harder to demonstrate. In the study from Thompson et al. In Vancouver, these 45 individuals did not show a difference in nerve conduction velocity monitored over 6 years between the time when they were followed with intensive medical management versus subsequent to receiving islet cell transplantation, while the group from Lille, France, followed their cohort of islet transplant recipients for 5 years and demonstrated improvement in sensory but not motor nerve conduction velocity. And finally, there's been demonstrated effect of islet transplantation on improving health-related quality of life, shown here, especially for diabetes distress and hypoglycemia fear, with data derived from the Clinical Islet Transplant Consortium multi-center phase 3 clinical trial, where over 2 years of follow-up, individuals had significant and marked improvement in measures of diabetes distress and hypoglycemia fear. And these improvements were personally and statistically significant in these individuals, regardless of whether they continue to require insulin therapy for the maintenance of near normal glycemic control. So in conclusion, Restoration of C-peptide in individuals without residual beta cell function has a marked impact on clinically important measures of glycemia control. Less C-peptide is required to reduce risk for clinically important hypoglycemia, with incrementally more C-peptide associated with improved measures of average glycemia and time in range and reductions in insulin requirements. These relationships are remarkably similar to those observed in type 1 diabetes with residual beta cell function. Restoration of even insulin-dependent beta cell function is associated with recovery of glucose counterregulation, stabilization of secondary complications, and improved quality of life. These outcomes confirm the clinical significance of C-peptide as a biomarker for preservation of beta cell function. I'd like to thank my mentors in transplantation, Dr. Ali Naji, and in metabolism, Dr. Karen Teff, who's now at NIDDK, and my colleague, Dr. Chen-Yang Liu, who directs our islet isolation facility that was critical to our contributions to the Clinical Islet Transplant Consortium and the Cloud Islet Transplant Registry. Additional thanks to my colleagues at CITR that participated in the analysis of C-peptide relationships to clinical outcomes that I presented, David Bidell and Rodolfo Alejandro at the University of Miami, and Cassandra Ballou, Elizabeth Payne, and Franca Barton at MS Corporation. And thank you to the NIH, the JDRF, and the W.W. Smith family for their support of islet transplantation at the University of Pennsylvania. And thank you for your attention.